Great. So greetings to all of you. So till people join, let me introduce myself. So I am Dr. Shivaam, a young ENT and head neck surgeon, and I have been into NEET PG preparation and guiding the NEET PG aspiration for last 5 years. So my aim, my intentions are inclined with you. That means I also want you to get your dream seat. I also want you to get the results of whatever hard work you are doing, right? So today our session will be intended to give you the maximum value that we can give in this short time. So you can always interrupt me in the comment section, ask your queries, and if there is anything, because I'll be looking to your comments, I'll be asking you some questions, so we'll keep it little interactive, and believe me, you are going to get hugely benefited by this session. Now if you are a NEET PG aspirant or someone who is studying MBBS, this platform is giving you a huge value. So they have a great educators with them now and more structured, more values. So there are different programs that are there and they are running the current batch for NEET PG 2021 and the next examination. So you can always uh, means try to there are several free videos, as well as if you want to get enrolled, you can enroll with them, you can check out them, and if you feel so, you can go towards them. Now straightforward to our first question, which was asked in AIIMS examination. Identify the structure which is marked here as A, right? So if you see, this structure was marked as A in your examination, right? So what you think this structure is? Is it any ossicle or is it any other structure? Now my intention of giving you this picture and their intention is to make you know that now they are asking intraoperative pictures. So you should be well accustomed with the intraoperative picture and the landmark. So we'll see, first we will see what all structures you can identify in this figure, right? So this figure is a figure of cortical mastectomy, and what all structures you can delineate here. One ivory white structure that you can delineate here is your lateral semicircular canal, right? So this here, the structures that they can ask in future from this picture is, one is your lateral semicircular canal, which is the landmark that you get on the medial wall of antrum, that maxillary antrum, right? So it is present medially. While you do the cortical mastectomy on the medial wall, you will find an ivory white structure that is lateral semicircular canal. Okay, another structure that you can delineate is your facial nerve, the vertical part of facial nerve that is running just behind the posterior or the external auditory canal, posterior wall of the external auditory canal, to orient you if this is your anterior, right? If this is your posterior, this is superior, and this is inferior. So if I ask you, what is the superior limit of cortical mastectomy? So you all know that the superior limit is tegmen antri, or you can say the middle, the tegmen plate. That means that bony plate which is separating the middle cranial fossa from the mastoid cavity, right? So this thin bony plate which will show you the pinkish color on drilling is your tegmen antri superiorly. Posteriorly, you can see a bulge here, a bluish bony bulge. So this is your sigmoid sinus. Posteriorly lies the sigmoid sinus. Anteriorly is again your posterior wall of external auditory canal, right? And inferiorly is your DR, doctor, or digastric ridge. So this digastric ridge, the significance is the plane of this digastric ridge is similar to the plane of facial nerve. So while you are searching for facial nerve, you first go inferiorly and find this digastric ridge. So this is the ridge which is formed by attachment of digastric muscle over the bone, and while drilling you can delineate, you can see that the muscle fibers are seen, so you can identify this digastric ridge and then you can find the level of facial nerve. Now question remains, what is this A? So this A that you are seeing after you have done your cortical mastectomy and you have found your maxillary antrum is your incus. This ossicle, the shadow, a part of incus you can see here. So this ossicle, the answer here will be incus. Now coming to some more pictures to orient you. So for this the answer is incus, right? Let me use the pen. So here the answer is incus. Now it will become more clear once we see some more pictures and some more probable question. Now here they have marked with another letter, that is B. So if I ask you what is B, again this is a cortical mastectomy done, but here another procedure have been added with the cortical mastectomy. So here you can see one another space which is the entry to the middle ear space through the cortical mastectomy. So here along with the cortical mastectomy, one more procedure is done, that is called posterior tympanotomy, right? So this posterior tympanotomy can be the second question that they can ask you in the coming AIIMS or NEET PG examination, because now they are into your mastoid cavity, they are into the surgical drilling and surgical pictures. So very high probability that the next picture that you might get will be this one. So posterior tympanotomy, you all know, is an important procedure for a surgical treatment which is the cochlear implantation, right? So very important topic again, cochlear implantation. And in cochlear implantation, to insert the electrode into the inner ear, into the scala tympani, you have to do posterior tympanotomy after the cortical mastectomy, right? So here cortical means posterior tympanotomy is being done, and again you have to know the boundaries which you will delineate or which you will find to do this procedure, right? So the boundaries for cortical mastectomy, again here you can see your the mastoid segment or the vertical segment of facial nerve. Above you can see, what you can see is your chorda tympani nerve, and superiorly is your incudal buttress or superior incudal buttress. So this here B is your incudal buttress, right? B is your superior incudal buttress. So if they ask you by giving this picture, now you will be able to tell what all things are there. And again here if you can see with little focus, one white ossicles is seen, and this white or yellowish ossicles is seen, that is incus, right? And to orient you again, this is your superior, inferior, posterior and anterior. This is your posterior canal wall, right? Now this is a more labeled one. Yes. So most effective, one question is being asked here, okay, what is the most effective way of studying? So see, there is no best way or the most effective way. You have to individualize how things are working for you. If you have read something and you are feeling like now it is getting boring. You cannot revise again from the notes. You are not able to revisit the videos. Try doing some MCQs. Try going retrospective. Read the MCQs and then go to the text. So this will make you more oriented, more excited towards that subject. And anyway, the motive of yours at present time is to make your weaker subjects, weaker topics, weaker question strong. Because once you start removing your weaknesses, you will reach a level that you will be getting selected. So the main motive, or you can say funda of getting selected, is to find out your weaknesses. Try giving the grand test, the test series on a regular basis. Find your weaknesses and keep on improving. You will get your dream seat, right? So again, moving to our orientation, that is one more picture of a cortical mastectomy. Here again, if I give you the orientation, this is superior, this is inferior, this is your posterior, and this is your superior. And if I ask you now, tell me where will be your lateral semicircular canal, right? So see, this is again the bulge, ivory white bulge is your lateral semicircular canal. Perpendicular to it is your posterior semicircular canal, and your superior semicircular canal will be somewhere here. This is your tegmen antri, this is your digastric ridge, posterior canal wall, right? Sigmoid sinus bulge. Okay, again the same picture, the orientation is different now. Superiorly is your superiorly is your tegmen tympani, inferiorly is your digastric ridge, superiorly or anteriorly, you can say, not superiorly, anteriorly is this, and inferior is this. So again, a bulge, a bluish bulge, you can delineate inferiorly, which is not inferiorly, posteriorly. So a bulge, bluish bulge, you can delineate posteriorly is your sigmoid sinus bulge, superiorly is your tegmen antri, right? Inferiorly here you can see your digastric ridge. At the same level you can see your facial nerve, posterior canal wall, and this was the structure that was asked. So this is your incus, which is showing here. So this part is your incus. Above it is your malleus, or you can say malleoinguinal joint. But if they ask you which is the first ossicle, or if they mention here, mark incus, because it is the ossicle which is seen, the most part of incus is seen, not the malleus. Malleoinguinal joint is seen once you do epitympanotomy, means if you drill more upwards towards the zygoma, you can see this malleoinguinal joint as well, right? So revisiting all these, I think by now you all remember this. And one more basic thing that you need to know is about two landmarks or two triangles, right? So you need to know two triangles, and I know all of you know this. One is McEwen's triangle and another is Trotman's triangle. So mind that both have different significance, both have different boundaries, right? So if you ask me about McEwen's triangle, this is a surgical landmark for maxillary antrum. This mastoid antrum, right? So this is a surgical landmark for mastoid antrum, and the boundaries are again your posterior canal wall. So this is already a drilled bone. For McEwen's triangle, you need the normal temporal bone, and on that the boundaries are posterior canal wall, right? And there will be one inferior temporal line or suprameatal crest, and a tangent which will be running, right? So a tangent running from the posterior canal wall to this suprameatal crest or inferior temporal line, and this triangle is the thing that is called McEwen's triangle. Now how this McEwen's triangle is different from Trotman's triangle? Trotman's triangle, or one more triangle is there, triangle of attack, right? So first we will discuss triangle of attack. So triangle of attack is different from McEwen's triangle. How? This triangle of attack is the triangle by which you do cortical mastectomy. So this triangle, the boundaries are same that you do for a cortical mastectomy. So superiorly will be your tegmen antri, right? Inferiorly will be your, or you can say posteriorly will be your sigmoid sinus, and anteriorly will be your posterior canal wall. Inferior is the joining of the posterior canal wall with the sigmoid sinus. So this triangle of attack is the triangle where you start drilling for doing the cortical mastectomy. So McEwen triangle is surgical landmark for your mastoid cavity, mastoid antrum, and triangle of attack is your boundary for doing a cortical mastectomy. Now, as they are into the intraoperative pictures, for just your knowledge, you have to know the endoscopic anatomy of the middle ear, right? So they can give you this picture, which is the endoscopic anatomy or the structures of the middle ear. Don't get worried, you need not to know everything here, but some vital structures like this. The prominent ossicles that you can see on the front is your malleus, right? Malleus is attached, and now you can see your long process of incus here. So behind is your malleoinguinal joint that we cannot see, but this part is your incus, right? Here you can see stapes head, which is attaching to the incus, or you can say to the lenticular process of incus. So this is your stapes head, right? And here you can see your stapedius muscle. So this is your stapedius muscle, and you all know that this stapedius muscle is arising from a bulge, that is a ridge called pyramidal process. So see how many great structure now you can identify. So this middle ear is really a magical thing where a lot of important structures are there, and that is why it is important for you to know. Now what is this bulge that you can see on the medial wall of the middle ear? So this is nothing but your promontory. So promontory is the bulge that is caused due to basal turn of, yes, cochlea. Yes, very true. So this is basal, caused by basal turn of cochlea. Now if I ask you, what is this? What is this, which is a horizontal whitish thing running in a bony canal over the middle ear? So this is, yes, this is nothing else but your facial nerve. And which part? The horizontal or tympanic part. Horizontal or tympanic part of the facial nerve. So it is very important for you to identify these structures, because if they ask you, you should be able to identify them and tell these things, right? Now again, this is another endoscopic picture which is taken from a different view, and here what all you can see, here you can see your malleus. Wait, you can see your malleus bone here, right? Tensor tympani tendon, which is curving around the processus cochleaformis and arising at the neck of malleus, right? This is your long process of incus attaching to the lenticular process attaching to the head of stapes, right? And here you can see again stapedius muscle, pyramidal process, and one nerve you can see which is crossing over or above this long process of incus, which is your, this nerve is chorda tympani, right? Chorda tympani nerve. So many a time while doing the stapes surgery, what we do is, for the exposure, this chorda tympani nerve get stressed, and in post-operative phase the patient feels dysgeusia, or difference means anterior two-third part of taste is affected due to this chorda tympani stretching during the surgery, right? So if they ask you this nerve which is running over the incus, it is your chorda tympani nerve, right? So this chorda tympani nerve is also important. And again, one last endoscopic picture which is similar to it, just you need to identify these structures and we'll be done with it. So this is again malleus, this is incus. So note that your malleoinguinal joint will not be seen, it will be above. So that is why it is behind the malleus is articulating with the incus, but due to this ridge, if you don't drill it, so won't be able to see it. So this is incus, right? And here again your incudo-stapedial joint, which is a synovial joint. So your incus is attaching to the head of stapes. Here you can see your pyramidal process and the stapedius muscle, and stapes has anterior and posterior crura. So you are not able to delineate in this picture properly the anterior and posterior cruras, right? But if I ask you what is this that is shown by the arrow, so let me know what is this structure, white glistening structure which is running under the bony canal. This is your tympanic segment of facial nerve, right? Tympanic segment or the horizontal part of the facial nerve. Now you can see another depression here which is surrounded by a bulge. Can you tell me what is this? So this is your round window niche. This is your round window niche. Okay, and oval window is covered by the stapes footplate and the stapes anterior and posterior crura. So that is why it is lying somewhere here, but we are not able to delineate. So as this is a revision session, we'll be little fast. Okay, again a middle ear picture where you can see over the promontory the plexus, that is the plexus, tympanic plexus you find. So this is the Jacobson nerve, again your incus, malleostapedial joint, facial nerve, your pyramidal process and the stapedius muscle. This is your round window niche, and this is your promontory where you can see the tympanic plexus. And this is just to give you a orientation about the ossicles and their part. So this is your manubrium of the malleus, then comes the neck of malleus, then comes the head of malleus. So these are the different parts of malleus. Here you can find the umbo, which is attached with the head of this, not head but the tip of malleus. Then comes the manubrium, lateral process, neck of malleus, and head of. Now this head of malleus is attached with the incus, right, through malleoinguinal joint. So what parts we have? This process that you can see is the short process or short crus of incus. Then comes the body of incus, then the long process of incus or long crus of incus that we were seeing there. And this long process of incus is having at the end the lenticular process of incus, which articulates with the head of stapes via incudo-stapedial joint, okay, synovial joint. And then you have your anterior crus and the posterior crus of stapes, and finally the stapes footplate which is resting over the oval window, right? So things are now pretty clear for you, and you can now answer any amount of question or any modification of the previous question if they ask you in your future examination. Now this is again an important question which is related with your tuning fork test. Gillies test is done in. Now the answer is pretty straight, but first you need to understand what is this Gillies test and how this test is being done. So the instrument that you are seeing here is called Sigel's speculum, right? So it has a rubber bulb and one eyepiece. which has a convex lens for magnification. So what magnification it produces? 2.5x. So it magnifies the tympanic membrane image by 2.5 times. Then it has a ear speculum, right? So through this pneumatic sigils speculum, so we add here a term that is called pneumatic sigils speculum. We can do various procedures. We can do some audiometric test. What we can do is, another thing is, we can use it to instill some medication in the ear, and we can do fistula test. So lot of application this instrument has. So you can do fistula test, you can do it, use it for medication procedure, you can do it for different tests. Like in Gillies test, we will be using this pneumatic sigil speculum. Now what you do, or what we do in Gillies test? So basically in Gillies test, we are testing the bone conduction of the patient. And what you are doing in Gillies test? What we are doing is, we are placing the tuning fork. Okay, yeah, so we are placing the tuning fork over the mastoid bone, the mastoid cortex, cortical part of the mastoid process, and we are increasing the intra-auricular pressure. How you are increasing the pressure? You are increasing the pressure in the extra-auricular canal, or the EAC, external auricular canal, in the EAC by this sigil speculum. So what you want to see? You want to see that with this increased pressure, what is the effect on the hearing of the patient. So let us assume two conditions. One where we are increasing with the sigil speculum, and the second when it is normal. So when you are increasing the pressure in the external auditory canal by the use of sigil speculum, what will happen? Your tympanic membrane will experience a pressure and it will get pushed inside. Ossicles will be pushed inside, and thus finally this increased pressure will get transferred to the inner ear by the stapes footplate. So footplate will compress the oval window and it will increase the intralabyrinthine pressure. Now what this intralabyrinthine increased pressure is going to do? This increased intralabyrinthine pressure is going to immobilize the basilar membrane, and with this immobility or fixity of this basilar membrane, what will happen is the patient will experience a decrease in hearing, right? So there will be decreased hearing when you are using a pneumatic sigils speculum in a normal patient. But what will happen in a condition that we called as otosclerosis? So in otosclerosis, you all know that there is fixity of the ossicles, right? So assume that a patient with otosclerosis comes to you and you are doing a Gillies test on him. So what will happen? Due to this fixity, tympanic membrane will be giving the pressure in the ossicles, but ossicles are not transferring this increased pressure to the inner ear, right? Why? Because ossicles are fixed, they are not moving. So due to this fixity, now there is no increase in pressure in the inner ear, and then there is no increase, or there is no immobility of the basilar membrane, and thus the patient will be hearing normal as before. So there won't be any change in hearing due to increased pressure by sigil speculum. So no change in hearing when ossicles are fixed. So how you are going to interpret this? This part is really important. You will say negative Gillies test when there will be no change in hearing with the use of sigil speculum. So when the ossicles is fixed, like in case of otosclerosis, or disconnected in case of trauma or something, many a times ossicular joint dislocate. So in both these situations, you will get a negative Gillies test, right? And a positive Gillies test means you are getting a decreased hearing with increased pressure. So why the interpretation is important? Because this time they had just asked it is used in. So by now you know that it is used in your otosclerosis. But in the next they can ask you whether Gillies test is positive or negative in otosclerosis. So mind that Gillies test is write me in the comment. It is, yes, write me. So Gillies test is negative in your otosclerosis, right? So these tuning fork tests, you might get one question. Rennie's test, you all know that. The interpretations also, you know that air conduction is always better than bone conduction in case of normal and in case of SNHL, right? And it is negative when the bone conduction is greater than air conduction in case of conductive hearing loss. So in case of conductive hearing loss, you know that your bone conduction will be greater because air conduction is decreasing. The conduction, there is some defect in the conduction, in the air conduction part, or through the ossicle, through the tympanic membrane, and thus the bone conduction will take an upper hand. Now the question they can ask is when you get a false negative Rennie's. So you can say that in unilateral severe sensory neural hearing loss you will get a false negative Rennie's, right? Weber also, you know, there is means this, the interpretation, you all know that in conductive hearing loss it is lateralized to the poorer ear, and in sensory neural hearing loss it is lateralized to the better ear. So there is one mnemonic by which I used to remember it, that is called BUS. So in sensory neural hearing loss, Weber will be lateralized to better ear. So you can always use some imagination, some mnemonics to not to get confused in the examination. And one another test that can be asked is the binge test. So that's why I wanted to discuss it here. So it is again a bone conduction test, right? And examination, it what it does is, it is again what we are doing is it examines the, here we are not using the sigils speculum. What we are doing is we are occluding the ear with the help of tragus, right, and seeing ki how hearing is affected. So again we are placing the tuning fork over the mastoid and pushing the tragus inward, right? So we are closing, we are alternatively closing and opening the external auditory canal, and see what inference, what results you get. In normal or sensory neural hearing loss, when your canal is occluded, you will hear a louder tuning fork. Why? Because in normal cases, what you are doing with occluding the ear canal is you are stopping the air conduction part. So it's obvious that in normal patients your bone conduction will be louder. Your tuning fork will now be more than your air conduction. Bone conduction will be more than air conduction. It will be louder than the normal, because air conduction part, the interference is stopped, and this is said to be binge positive, being positive. And in conductive hearing loss patient, so see, if you are doing it in a patient with tympanic membrane perforation, let us suppose that patient has a tympanic membrane perforation and you are doing this binge test on him. So if you occlude the external auditory canal, then also he will be hearing the same amount of tuning fork. Why? Because before also he was not able to hear through the canal. He was having a conductive hearing loss. He was having decreased hearing through the air conduction part. So it doesn't matter that whether you have occluded or it is open. In both the scenarios, as air conduction is affected in conductive hearing loss, there will be no change in hearing with occluding the external auditory canal, and then binge test will be negative. Now I know that things will be little uh, complex for you, but try to get the concept and just make it right if they ask you in the examination, because that is the main motive of Means I can say you that even if you forget this after examination, it really doesn't bothers me. My main motive, your main motive should be only to, means this should not be said, but I want you to get through the exam in whatever way and try to just keep them with you till the examination, and then do whatever you want to do after the examination. Now just for your sake of MCQ, they can ask you ki what all tests are there to detect malingering. Okay, so malingering patients might come, they might come to you and they say that they have got a hearing loss. Why? Because to get a handicap certificate. So you should know, being a doctor, you should know how to detect these malingering patients, because you know in our country reservation system is there. So these means they deserve the reservation, I'm not saying that, but yes, malingering patients you need to rule out, otherwise they will take the undue benefit. So there are different tests, just note their name. One is Stenger's test, Teal test, and Chimani-Moore's test. So they won't be asking you what all you do, but they can give you these things in the option for detecting malingering patient which are coming to your OPD, right? Now, best surgery to relieve intractable vertigo in Meniere's patient. So this is again a question from AIIMS, right, which was asked. So best surgery to relieve intractable vertigo in a Meniere's patient. If you see the options, one is surgical labyrinthectomy, vestibular neurectomy, endoscopic sac decompression, and final and last is cochleosacculotomy. So you all know that in Meniere's disease, what happens? So in Meniere's disease or endolymphatic hydrops, so it is also called endolymphatic hydrops. So there is back pressure or increased pressure in the sac, and this increased pressure in the endolymphatic sac can be caused by either obstruction in this endolymphatic duct or increased production of the endolymphatic fluid. Now if endolymphatic fluid is produced in great amount, then also the pressure will increase and patient will feel the symptoms of Meniere's disease. Or if there is obstruction in the outflow, that is endolymphatic duct, again the patient will feel the symptoms of Meniere's disease. And we all know that the symptom is TVS. So TVS is Scooty or TVS activa, tinnitus, vertigo, and the sensory neural hearing loss. So this question is more towards treatment. So we will be discussing what all we do. So first we start our patient on medicinal therapy. So medicinal treatment, you all know, in acute stages, when the patient has presented to us in acute stage, you give some labyrinthine sedatives and antiemetics, and some other things like benzodiazepine and others can be given depending upon the symptoms. Then you follow a regimen that is called Furstenberg regimen. So just know what all are there. If you don't know by now, you prescribe the patient on low salt diet, diuretic, potassium chloride, high protein diet, beta histine to relieve for vascular ischemia. So beta histine, a drug which is prescribed or can be prescribed in this to relieve the patient on vascular ischemia. It can also be given in BPPV and others, so to relieve the vertigo and to reduce the vertigo. And you will advise the patient to stop caffeine, nicotine, alcohol and tobacco. Now coming to the protocol, what you will do. So first you will advise or start the patient on first line of treatment, right? So you will start the patient on low salt diet, oral diuretics. Second, if still the symptoms are not getting relieved, you will try intratympanic steroid therapy. You will try to place a tympanostomy tube and give some medication. There is one instrument that is called Menet pump. What it does is it provides some positive pressure to relieve this sac extension or sac distension. So you can use a Menet device to relieve, and finally you can do an endolymphatic sac decompression surgery. right? So endolymphatic sac decompression surgery is a surgery that is again done through the cortical mastectomy route, and then what you do is you open up the endolymphatic sac so that it get decompressed. You can try using intratympanic gentamicin therapy, vestibular neurectomy, and finally, if things doesn't help, the best way is labyrinthectomy. Okay, so this labyrinthectomy, what you are doing is you are totally destroying the labyrinth, and that will help you to stop all the symptoms, that is the vertigo and all, completely in that patient. So this labyrinthectomy is the best or the definitive treatment in case of intractable disease. Note my point, in case of intractable disease. Intractable means when these modalities are not working. So you will go step by step, first line, second line, third line, fourth line, and then finally the surgical destructive thing, that is the labyrinthectomy. Now if we revisit our question and see what our examiner wanted to ask, he had asked best surgery. So let me choose the pen. Best surgery to relieve intractable vertigo in Meniere's patient, right? Best surgery, one word, intractable vertigo, second word, in a Meniere's patient, third word. So write me what will be the answer, right? So the way we had discussed, we are seeing that our examiner want to perform a best procedure for intractable vertigo, and the answer then should be your surgical labyrinthectomy, right? Now in the option you have seen that means endolymphatic sac decompression. So endolymphatic sac decompression, to do this there is one line that is called Donaldson line. So you can get a MCQ on Donaldson line, that what is this line. So this line is basically to find or surgical landmark for endolymphatic sac. It is a line that is passing through the horizontal semicircular canal, bisecting the posterior semicircular canal. Now if you see this picture of the cortical mastoidectomy done, here you can see your lateral semicircular canal, right? So this line is along the lateral semicircular canal and perpendicular to the posterior semicircular canal, or bisecting the posterior semicircular canal. Okay, so what this line, how this line will help? This endolymphatic sac is just at the, or you can say just inferior to this Donaldson line. So if you open the bone and the dura in below this line, you will get this endolymphatic sac, right? So just remember this endolymphatic sac, the surgical landmark is Donaldson line, and this Donaldson line is a line which is passing along the horizontal semicircular canal, or the horizontal semicircular canal, bisecting the posterior semicircular canal, right? Right. Now again, a very important question, a very frequent one that you might get in your examination. Let us see what the examiner says. And before reading, just try to frame in your mind what all points you are going to mark out of question. In some examination like JIPMER, you get 7-8 lines of question. So in those things you need to see what all are important. So 14-year male patient presents with recurrent spontaneous bleeding from the left nose. On examination, a pink mass covered with mucosa was found, right, in the nasopharynx. Which of the following is not to be done? 14-year male, recurrent spontaneous bleeding from nose, a pink mass covered with mucosa in the nasopharynx. Which of the following is not to be done? So if you See the way examiner have asked your question, you are definitely clear that it is a case of JNA, juvenile angiofibroma. So nowadays this naso part is omitted and you mostly say juvenile angiofibroma. So it's pretty clear that the case is juvenile nasopharyngeal angiofibroma, which is a highly vascular. You can say we, being the ENT surgeon, we take a lot of precaution while operating on these JNA because these are highly vascular tumor and they are locally invasive. Now, highly vascular tumor, that is fine, but why we are so much cautious against it? Can anybody of you tell me why we are so much cautious about these JNA? Because these JNAs in their architecture, they don't have tunica media. So these JNAs don't have this tunica media in them. And what is the result or the result of this absence of tunica media is the blood vessels, once you injure them, once you traumatize them, the bleeding don't stop because they are lacking the contractile part which is there in the blood vessels. So mind that these lack the tunica media layer and that is why they bleed enormously. We always take some blood with us before operating, right? Another important point is what is the vascular supply. So main vascular supply of these vascular tumors comes from IMA, right? Internal maxillary artery. So internal maxillary artery contributes to the main vascular supply of this tumor and that is why before operating them during the surgery means our main aim to do the surgery is to get hold of this internal maxillary artery and then remove the tumor. So by getting hold of this internal maxillary artery, what we can do is we can reduce the amount of bleeding that will occur during the operation. So that is why you need to know, and the examiner might ask you, okay, what is the most common or the dominant vascular supply of these JNA. So it's internal maxillary artery. Now coming to how they are arising, right? So recent theories have given this proposition that they are the first branchial arch artery remnants. So what is happening is these first branchial arch artery remnants are staying there and forming this tumor, right? So it's a branch of, you can say this internal maxillary artery is a direct branch of the external carotid. Okay, so this has different parts, but the third part is the one from where this tumor will arise. And specifically if you see the first branchial arch artery that is contributing to this tumor is arising, from where this tumor is arising is your sphenopalatine artery. So remnants of this first branchial arch artery are giving rise to these JNAs and finally the sphenopalatine artery. So here you can see two normal structures and one abnormal structure. So this abnormal structure is your inferior turbinate and this is your nasal septum, right? And here in the middle you can say your angiofibroma. Now two important things that are related to it are, one is your X-ray finding, which is Holman-Miller sign seen on X-ray, right? Holman-Miller or the antral. So what is it? You see a bowing of posterior wall of maxillary sinus. So if this is your X-ray, you will observe there is bowing of the posterior wall of maxillary sinus. Why? Because behind is the tumor which is causing this bowing in the posterior wall of maxillary sinus. So if you see again the definitive treatment, or before treatment let us come to the investigation. So the ideal investigation is CECT. For diagnosis, the investigation of choice for diagnosis is CECT of the nose and paranasal sinus. So it will give you a contrast enhancing mass which is arising from the sphenopalatine foramen or the area of the pterygomaxillary fossa. So somewhere here, if you see, or in this part you will see, there is widening of the pterygopalatine fossa because of the tumor, right? And this is a hugely enhancing mass on CECT. Another important thing is you must have observed that for anything the definitive diagnosis you make is by doing biopsy, right? But as this tumor is so vascular, we fear taking biopsy. That is why the diagnosis of JNA is mostly a radiological diagnosis. For it we do a CECT. And here if you see a better image, you can see here this tumor in a CT scan axial cut, this tumor which is there in the nasal cavity, and there is widening of this sphenopalatine foramen. So this sphenopalatine, if you note on this side, on the right side, is narrow, right? But anytime if I orient you, this is your posterior wall of the maxillary sinus. Okay, so this is your maxillary sinus, and this is your posterior wall of the maxillary sinus, behind which is your pterygomaxillary fossa, and this is your sphenopalatine foramen. So here you will observe widening due to the tumor. So it is a sort of dumbbell shaped tumor that you can observe here, and this is a characteristic CT for diagnosing a juvenile nasopharyngeal angiofibroma, because it is arising from that region of the sphenopalatine foramen and the pterygomaxillary fossa. And you will observe that if you observe your right side and left side, you will observe there is anterior bowing or elevation of the posterior wall of the maxillary sinus due to this tumor. So this is again your Hallmer-Miller sign that you see on X-ray, right? And on histology you will observe that there is lack of tunica media. So I don't know, but they can still give you this histopathology, because this is so common and so important for you all, this angiofibroma, that you can still get this histopathology. So how you are going to identify? You will observe here some staghorn shaped blood vessels. So you observe these are some staghorn shaped blood vessels with endothelial cell but no smooth muscle, right? So these smooth muscles are compressed by the fibrous tissue, and you are not going to get the tunica media or the smooth muscle layer in the blood vessel. So this is a histopathology for JNA, and this is again a CT scan picture showing you a widened. If you compare from the opposite side, you will observe that this part is widened on the disease side, and there is bowing of the posterior wall of the maxillary sinus. Just compare on the right, it is normal looking, means just like this, and on the left you will observe that it is like this. See, it is like this. So this bowing, this elevation is caused by this JNA, right? Another important thing is how this tumor is spread. So if you observe, this tumor can spread to different areas through different foramens. So if you see this from sphenopalatine foramen, your JNA, your angiofibroma is arising, and it can spread to different parts, to the middle cranial fossa, to the sphenoid sinus, to the pterygopalatine fossa, to the infratemporal fossa. So lot more spaces to the nasopharynx it can go, and the route is the route is nasal cavity. It can go the nasal cavity from the sphenopalatine foramen. It can come to the nasal cavity, cause the nasal obstruction, epistaxis. It can go into the nasopharynx, where it will push the soft palate downward. It can go into the pterygopalatine fossa laterally. It can go into the maxillary ethmoid, sphenoid, and it can go into the middle, anterior, and other fossas. One more thing if they ask in future is regarding staging. So just remember that fish staging is for these JNA. for MCQ purpose, future reference, just remember fish staging is for JNA. And this is another a better picture of histopathology where you can see the staghorn shaped blood vessels where the smooth muscle layer is absent or tunica media is absent, specific for JNAs. Now, many a time some surgeons, what they do is, as this tumor is so vascular, we try to embolize this tumor. So what we will do is, we will do a angiogram of the carotid artery, right? So if you see the carotid is coming and its branch, then finally the internal maxillary artery main is supplying. So what we will do is, we will call an interventional radiologist and ask him to embolize the feeding vessels of the tumor. So if you embolize, that means if you interrupt the arteries that are supplying this tumor is basically sort of less dangerous for us. So we also do pre-embolization before surgery, right? And then we operate. So if we revisit our question and let us see now you are able to answer it or not. So the diagnosis we had already made that it is a JNA or juvenile angiofibroma. The question was, which of the following is not to be done? Now I am reading the options. You need to tell me which of the following is not to be done. Option A is biopsy is to confirm the diagnosis. Second is contrast enhanced CT scan. Third is endoscopic surgery. Fourth is pre-surgical embolization of the artery. So you all know that you are not going to do a biopsy. So biopsy is sort of contraindicated in this. So vascular tumor, why are you going to do a biopsy and get yourself into trouble? A CECT will help you to make the diagnosis. Endoscopic surgery will help you to remove the tumor, and pre-surgical embolization of the artery will help you to reduce the bleeding during surgery. So this was almost a very important topic that we have covered almost everything. And moving to another important question which was related to the tongue carcinoma, right? So they had asked you a question where they said that a 55-year-old male presented with a lesion of 2.5 into 3.5 centimeter on the lateral border of the tongue. There was induration. There is no associated lymphadenopathy. What is the staging according to 8th AGCC guideline? So it was asked in one of the AIIMS examination, and this was a recall question. Why I am saying that it is a recall question? There are possibility that things are missed, because if you see your 8th AGCC guidelines have something updated in them that is not mentioned here, right? So if you have seen your 8th AGCC classification, you will observe that from previous classification now they have included the depth of invasion of tumor. So depth of invasion of tumor is now making an important factor for staging your tumor. So your T1, T2, T3, T4 was initially, these are depending upon the size of the tumor. So it was pretty easy to classify. In T1, any tumor which was less than or equal to 2 centimeter was T1. Any tumor which was between 2 to 4 centimeter was T2, and any tumor which was more than 4 centimeter was T3, right? So pretty clear, pretty easy. If you see there is one lesion, so every time I have to select pen, so that's why the slides get changed. So if you assume there is any tumor, suppose it is here, so depending upon the size you were labeling it as T1, T2 or T3. Any tumor which was less than equals to 2 centimeter, any tumor which was between or greater than 2 centimeter and less than 4 centimeter, and T3 was anything greater than equal to 4 centimeter. But now you also need to know what is the depth of invasion for the tumor. Like they have mentioned indurated, they must have mentioned what was the depth of invasion. So in T1, any tumor which has a depth of invasion of less than equal to 0.5 centimeter. In T2, greater than 0.5 centimeter but less than 1 centimeter. In T3, it will be more than 1 centimeter, right? So very easy now also, but only thing is this 0.5, 1 centimeter, you need to know that what is the depth of invasion, and this can be pretty clear by doing a contrast enhanced MRI, right? So gadolinium enhanced MRI changes to T4, right? So it changes to T4 when there is moderately advanced or very advanced disease. So that is why your CECT is also required to see the bony involvement, bony invasion of the tumor. If it is very large, if you have to decide upon whether you need to resect mandible, do a marginal mandibulectomy or a hemimandibulectomy. So for any tumor, you need to take appropriate margin. So suppose this is a tumor, right? So let us see a condition, and this will give you an idea why CECT is important. So suppose that this tumor is lying in the floor around or near the floor of the mouth, near the jawline, near the tooth. So if you are not getting adequate margin of around 1 to 1.5 centimeter, and if it is going into towards the bone, then you need to sacrifice that bone also to get the margin. So what you do in CECT is you check the involvement of cortical bone, and if anywhere you find that cortical bone is involved, right, then you need to do hemimandibulectomy. Hemimandibulectomy means you have to remove part of mandible, half part of mandible on that side, for making the patient cure, right? But if you see that for only sake of margin you are taking a part of bone, then you can do marginal mandibulectomy. Marginal mandibulectomy means you will only take a part of mandible and not whole mandible. Why? Because here the bone is not involved. Whatever bone you are removing is only for the sake of taking a tumor free margin, right? So this was an important concept that your AIIMS people or NB people might ask in future. Now in that question they have mentioned that there was no lymphadenopathy, but what if in future you get a question where they mention about the neck node staging? So you must know that what is N0, N1, N2A, N2B, and N3 and N4. Sorry, not N4, N3 ABC. So NX is anywhere, TX or NX is cannot be assessed, right? N0 is no clinical positive nodes. N1 is single ipsilateral. That means if there is tongue carcinoma on the right side, same side neck node is present, which is less than 3 centimeter. Right? Now N1 is any lymph node which is less than 3 centimeter on the same side. Now N2, as N2 comes, the size for N2 is more than 3 centimeter, more than equals to 3 centimeter, and less than 6 centimeter, right? And N3, if you simply see, is more than 6 centimeter. Okay, so like T1 we had 2 centimeter, 2 to 4 centimeter, and more than 4 centimeter, T1, T2, T3. Here also N1, N2 and N3 we have, because in future if they mention that there was a ipsilateral lymph node which was of 3 centimeter. So for that you need to know that what is the grading for the size for giving or labeling N1, N2, N3. So N1 is single ipsilateral less than 3 centimeter. N2 is anything between 3 centimeter to 6 centimeter, and N3 is greater than 6 centimeter, right? So this is a simpler one. Now you see what is N2A, what is N2B, and what is N2C. or N2 means N3C. So N2A is single ipsilateral 3 to 6 centimeter. So 3 to 6 centimeter will be constant. It cannot be more than 6 centimeter in N2. But if it is multiple same side, you will label it as N2B. If it is single same side 3 to 6 centimeter, you will label it as N2A. And N3 is anything which is more than 6 centimeter, right? So when you are going to label it as 3ABC, just remember that if any patient present to you with contralateral neck node positive or neck node, big neck node, it will be N3C, right? If the tumor is on right, patient is getting a lymph node positive B or whatever be the size, on the opposite side it will be N3C. So anytime contralateral lymph node, you have to label as N3C, and N3A is lymph node which is same side but greater than 6 centimeter. N3B is you get bilateral lymph node, right? So you get a bilateral lymph node will be N3B, and N3C is you get a contralateral opposite side lymph node. Okay, so this was little extra which I wanted to tell you. Whatever you got is fine. If still you find things little cumbersome, it's okay, because yes, it was little higher part which I told you. Now this is very straightforward question which was based upon the caloric test, but many of you have fear about this. So calorie test was done on the right side with cold water. Eyes moved to the opposite side. Which of the following statement is correct interpretation of the nystagmus in this test? Now the question is pretty simple. Don't get worried by this term, that is caloric test, right? So caloric test, if you see, there are three modes by which you can do it. So one is bithermal caloric test, and third is cold air caloric test. So bithermal caloric test is the most commonly done test, where what you do is you take the water at 37 plus minus 7 degrees Celsius. That means you take both hot water and cold water. So hot water will be 37 plus 7, that will be 44 degrees Celsius, and cold water will be at 37 minus 7, that is 30 degrees Celsius, right? So it is your Fitzgerald-Halpike test. Okay, so not to go into too much detail for the sake of question, let us see what you need to know. So you all remember this synonym, that is cows. So cold water makes the nystagmus goes opposite, and warm water makes the nystagmus go on the same side. So how you will decide the nystagmus whether it is right or not? So you need to see the fast component of the nystagmus. So let me assume that this is your pupil, right? And you are doing your caloric test on this ear. So if your pupil moves like this, fast, so fast component is the direction of nystagmus, right? So if it is moving like this, so this part, that is the right to me, this is left to me actually. So left will be the direction of nystagmus. So we decide the nystagmus direction of nystagmus is the direction of fast component of nystagmus. So nystagmus has a fast component and slow component. This is the fast component, and when it returns to its normal position is the slow component. So in cold water, if you are doing the syringing with cold water, eyes will move to the opposite side. So cold water in the right ear, your eyes will move to the opposite, that is left side. So fast component will be like this, left, towards left, right? In warm, it will be on the same side. Warm water on the right will be right. So fast will be towards right, and then slow it will return to its normal. So very simple, pretty clear. This is the way by which your caloric test is being done, and you place this thing to observe the nystagmus in magnified view, right? So let us see this question. We revisit this question and see how simple it gets. they are saying that you are doing the caloric test on the right side with cold water. So what you expect for cold water, your nystagmus should move to cold is opposite. That means it should go towards left side or the left ear. So your fast component should be towards left. Now let us read our options. The first option says fast component to the left side. So they are asking you which of the following is correct. So mind it that you need to answer depending upon what the examiner wants to ask. So whether he is asking about correct or incorrect. So correct answer is your fast component or moving to the left side. Yes, it is true, because you see in cold your fast component or the nystagmus will be towards the opposite side. So you are doing it on right, the nystagmus will move to the left side, right? So now there were more questions that we wanted to discuss, but the time is limiting factor. We have crossed around 1 hour and I don't want you to overburden. This will be the last thing, very easy but important future MCQ that you might get in the exam, related to anterior ethmoidal artery. Now this is something an endoscopic surgeon is concerned of. Here you can see a anterior ethmoidal artery in a field, and what you need to remember is your landmark, that is called Kennedy's nipple. So what is the significance of this Kennedy's nipple? This Kennedy's nipple is the site at which the anterior ethmoidal, means in the CT scan of nose and paranasal sinus, at which you can see your anterior ethmoidal artery. How you are going to see? You will see that between the superior oblique, so I have already marked it. So this red thing is your superior oblique, this is your medial rectus, and between this is your anterior ethmoidal artery, which will be coming from the orbit into the nasal cavity, right? So this Kennedy's nipple is for anterior ethmoidal artery at the point in the CT scan where you can locate this artery between the superior oblique muscle and the medial rectus, right? So again in this picture you can see Kennedy's nipple, where the orbit is making Kennedy's nipple, from where this anterior ethmoidal artery is exiting from the orbit into the nasal cavity, right? So the thing is why we need to take precaution is this artery, if get injured in during the sinus surgery, it will retract into the orbit and might lead to the orbital hematoma and compression of the optic nerve, leading to loss of vision. So we need to know our anterior ethmoidal artery before we operate, right? So we need to take care we do not injure this artery. Now with this I'll end this session, and lot more wishes to you, lot more happiness to you, lot more health to you, and lot more success to you. Happy Teachers Day for today. And ending the session, this is Dr. Shivam, hoping that everything good happens with you, right? So it was a great interacting with you. Do give your feedback in the comment so that I can know how was the session, and you can always reach me out over the WhatsApp or over my own channel, and or over the Unacademy Telegram group. So you can join the Telegram group, the link is given there. And I would suggest to get into this Unacademy thing, because lot more important things are being discussed over the platform. So you can always download and try it out. It will help you immensely in your preparation, right? So see you, take